Okay, welcome back and thanks again for joining me for today's webinar. My name is Dr. David Kanashko. I am the Medical and Innovation Director here at BioFlex Laser Therapy, based in beautiful Toronto, Ontario, Canada. So a little bit of housekeeping before we get started with the webinar. I typically do webinars every month, usually one or two a month. They range from ones designed for healthcare professionals and also for our consumers at home as well. The webinars are always recorded and then we edit them, and typically they are uploaded onto our website in about a week or two after the actual broadcast date. Should you want to watch a webinar and you know you can't make it or whatever, just register and you should be sent an email, although sometimes the odd person's left out of it, but usually we send an email that has a link to watch it again. And if that doesn't work for you, then just go to our website, bioflexlaser.com, and go to support. And under support, you will see webinars, archived webinars, either for professionals. Anyone can watch these, by the way, whether you're professional or not, and also for consumers or personal therapy systems that we offer as well. So for today's webinar, what I wanted to do is give some groundwork to treating the signs and symptoms of post-concussion syndrome. And this is kind of, I'm doing this because, in part because there's a high demand and high need for it. I'm also will be doing some advanced certification trainings in this type of treatment. And the first one is in Vancouver this weekend. So I'll be going into obviously a lot more detail and practical work, that kind of thing. So I'll also be repeating that in the fall time in and around the Greater Toronto area in person. So any professionals watching in and work in the area or practice in the area, then pay close attention to that announcement sometime in the next month or two, and you can join us live for a little bit more information. Should you have any questions as we go along, just type them into the chat box. I am finding difficulties with the question box, so I prefer if you just typed it into the chat box, your question. Okay, so let's get into it. I do have a lot of slides. I will try to get through it as efficiently as possible. As you can imagine, it's a massive topic. I'm really only touching the surface today. I do go into a lot more detail and a lot more parameters in the certification training course. And of course, anyone that's dealt with a concussion or post-concussion syndrome, or professionals that deal with patients that have these issues, it is multifactorial. There's so many different types of symptoms going on and body systems that can be affected, from somatosensory and fatigue and cognitive issues, anxiety, autonomics, headache, muscle, you name it. There's lots of things going on here. So hence, it's a very challenging and difficult type of condition to treat. Now, when we talk about treating something like a concussion, there's a term that is often kind of used in research, and it's called photoneuromodulation. So essentially, this is the use of photons or photonic energy or light energy, and it's absorbed by neurons. Now, you know, we treat nerves, of course, when we treat other conditions in the body, but specifically, we're talking more about the central nervous system with concussion. And this light activates bioenergetic signaling pathways. Although that sounds kind of, you know, a little out there, there's a lot of science and research out there to understand what I mean by that. And it's pretty straightforward. It's not something that's, you know, a little bit, how should we say, alternative. This is actual pretty much science here. So the most abundant metalloprotein in nerve tissue happens to be cytochrome C oxidase. And if you're familiar at all with the concept of photobiomodulation or laser therapy, you know that the main target for light is cytochrome C oxidase. When this enzyme absorbs specific wavelengths of enough dosage, then it correlates to specific enzymatic activity and especially ATP production. And again, you don't need to be a healthcare professional to know that ATP is what drives energy in our cells. When you have lots of energy in your cells, then, well, you're very active. When you have lower amounts of ATP, not so much. Some of the stats, now these are American. In the advanced training course, I'm going to gear it more towards Canadian. But, and this is getting a little bit old, these stats, so it will be probably a lot higher than this. But in the US, for example, 1.7 million patients are evaluated for traumatic brain injuries every year, on average 3 TBIs every minute. And it's estimated there are well over 5 million Americans living with TBI-related disabilities. And it's a huge cost and burden to the not just the healthcare system, but the socioeconomic aspects of into the billions and billions of dollars. It's obviously a real problem. On the bright side, there's a bright side to all this, is the fact that these traumatic brain injuries, right? They're usually mild. So the vast majority of these are mild or MTBIs. So they do have a better prognosis than more serious ones. Most patients that suffer from TBI, they typically have spontaneous resolution of their symptoms. But unfortunately, and this is where post-concussion syndrome comes in, they can become chronic and they can linger and then negatively affect the patient's daily cognitive function. So we talk about post-concussion or post-concussive syndrome. Really, these are symptoms that are most often prolonged mild TBI patients. But I mean, they can occur obviously in more serious, like moderate or severe TBIs, where you actually see on a CT scan or an MRI, issues inside the brain. But typically with mild TBIs, you don't see anything with imaging. So PCS, post-concussion syndrome, I'll refer to it as PCS, is a constellation of a series of different types of symptoms, from cognitive, behavioral, emotional symptoms after traumatic brain injury. And this results in lots of different types of symptoms, as I touched on earlier, like headaches, fatigue, vision issues. That's a very common one. Disturbances in balance. Sometimes you get tinnitus and dizziness, difficulties with sleep, neuropsychiatric symptoms like depression and anxiety, and even PTSD, difficulties with concentration. Now, approximately 90% of concussion symptoms are transient, and they usually resolve within a couple of weeks, may linger for a few weeks, but that generally speaking is how it goes. Persistent chronic post-concussion syndrome, well, this is where you have issues going past 3 months. I mean, if a patient's coming in, they say they've had ongoing symptoms after concussion, and it's 2, 3, 4 months later, you're dealing with a PCS kind of scenario. 15%, although this is probably a very low number estimate, of mild TBIs will suffer from PCS because a lot are unreported. And these are the patients that will experience persistent symptoms and oftentimes require further evaluation and treatment. Research has shown that mild TBIs resulting in persistent PCS has lasting effects on cognitive functioning, memory, learning, executive function. Very challenging to get back to, especially high functioning tasks, depending on your occupation or what you like to do, you may have difficulties with that. When we talk about the etiology or how concussion occurs, well, I think we all kind of are aware of that. There's direct impact, you get hit in the head by something, or acceleration, deceleration injury in a car, in a whiplash scenario. I'd have to say, in my experience, now I'm a chiropractor and I've been practicing quite a few decades now, gosh, over 30 years. And the thing with this is that when a person gets in a car accident and they go, oh yeah, I'm okay, no, it's just a bit of stiffness or whatever, and they tell their insurance company, no, I'm fine, really no issues or whatever, 2, 3 weeks later, they get the symptoms of concussion. And they go, whoa, like, where is this coming from? Meanwhile, they told their insurance company they're perfectly fine. So you can see the advice here is that if you're in a whiplash accident, don't say anything about how you're doing until you wait it out to see, because these symptoms can take a little bit of time to manifest. And blast injuries. Now, this isn't common in regular day-to-day life, but very common, as you can imagine, in the military. And so a lot of veterans have PTSD, and it's related to concussion, right? And I'm sure you've all heard about this. It's a serious problem. In fact, a lot of the funding in the United States has come through the Veterans Association and money through the military to investigate how photobiomodulation might be helpful with a post-concussion syndrome secondary to blast types of scenarios. And as I mentioned, you can see below here all the different symptoms. I think I've already kind of mentioned those. In most cases of PCS, again, they occur in patients that have mild TBIs. Blunt force, head trauma, sports-related injuries, that's a big one. They've been changing the rules around soccer, or you can say football in other areas outside of North America, because heading the ball as a youngster can really put a lot of excessive stress on the brain and lead to concussions. So they're actually avoiding children and adolescents from heading the ball too soon, because these can cause ongoing issues as well. Another common, unfortunately, a common cause of concussion and then post-concussion syndrome is in assault, and especially with women and physical abuse that's unfortunately too prevalent in our society. A mild TBI, well, that's defined as a Glasgow Coma score of 13 to 15. If you're not familiar with this, I will be going over this in a little bit more detail in the advanced training course, but you can certainly find that online. And complicated mild TBI comprises symptoms of concussion with associated head CT abnormalities, including hematoma, subarachnoid or subdural bleed, midline shift, or fracture. So that's a little bit more of a serious type of scenario. As I mentioned, uncomplicated mild TBIs, they actually normally have a normal head CT scan. Patients with uncomplicated mild TBI are more likely to have resolution of symptoms, and typically in a month or two. Patients with complicated TBI or more than one TBI historically are more likely to suffer from PCS or persistent PCS. There's other risk factors, including sex, more common in females, probably because it's more reported. That's usually how it goes. Psychiatric history of issues like depression or anxiety, or a history of chronic pain syndromes like fibromyalgia, as an example. Pathophysiology is extremely complex when it comes to concussion, and it's a combination of metabolic, physiological, and microstructural injuries to the brain. Symptoms are consistent with PCS, also involve the autonomic nervous system, where you see weird kinds of issues, everything from, sweating to inner ear issues, blood pressure issues, orthostatic hypotension, some unusual kinds of issues. And in part, this might be due to damage to the white matter tracts between the cortical control centers and the vagal nerve via the spinal cord. And this can affect the sympathetic and parasympathetic nervous systems. And this oftentimes correlates with symptoms of depression as well. Autonomic nervous system damage, as I mentioned, has lots of interesting symptoms, so you should always kind of be aware and look out for these symptoms. I've already mentioned most of these already. Both structural and biochemical changes have been described and documented in animal and human studies, such as increased atrophy and increased regional volume loss of brain matter. So this is pretty important. The cardinal symptoms presented in PCS patients include headache, dizziness, sleep impairment, and these all in turn are similar to somatization seen in psychiatric disorders, including depression, anxiety, and post-traumatic stress disorder. So looking at the symptoms physical-wise, well, we mentioned headaches, even nausea and vomiting, especially in the first day or two after a concussion, visual changes, very common are sensitivity to light or sound. So So be aware of that. And if you're treating concussion patients, a post-concussion syndrome, oftentimes you'll need a darker room, less light, that kind of scenario, quiet, no music being played. Might be changes in gait, certainly effects on fatigue, feeling tired, cognitive issues, everything from confusion and disorientation, especially shortly after the concussion, even amnesia, concentration difficulty, difficulty to focus, slurred speech, mental fog. And then, as mentioned, emotional symptoms could be everything from irritability. This is very common, sadness, depression. So again, when you're tackling these complex kinds of symptoms, really it's multidisciplinary approach. You know, as a chiropractor, I'm not dealing with someone's issues with depression and irritability. That there's other types of treatment that one should be referring the patient to. Light sensitivity, here's a few of the stats. 43% of patients experience painful light sensitivity after a head injury, so very common. 6% or thereabouts have light sensitivity that can persist 6 months later. So very common. And 85% have found relief using precision tinted therapeutic eyewear. So dark glasses is what they tend to wear. So you might suggest that as well. Cognitive deficits seen in anxiety, depression are similar to those in post-concussion syndrome. Sometimes antidepressant treatment can help. PCS has a good prognosis in general terms and symptoms and disability, and are the greatest within the first week in most cases. However, after 1 month, if the symptoms are improved, and most of the time are even resolved. So that's typically 1 month or so. But repetitive head trauma and greater severity of symptoms at initial presentation, this is where you tend to see symptoms persisting for longer than a month and leading to post-concussion syndrome. In a minority of patients, these can persist for many months, over a year. And there is biased reporting, and these numbers are oftentimes, it can be estimated with difficult accuracy. Sometimes it's overblown if there's legal issues. So it's hard to really get a true number on that. But there is a small number of patients that will continue with disabling symptoms that persist for several months or a year. The literature has reported patients with litigation and compensation issues, kind of that's what I was alluding to, that they may have more persistent symptoms. If you've ever worked with medical legal stuff, you'll know that. Repeated head injury resulting in concussions can lead to more severe cognitive deficits. However, more studies are being conducted to really understand the correlation of this. And patients with this is the Glasgow index score of 13, have higher rates of disability than with 15. So for that scoring, the higher the number, the better. Patients with complicated TBIs, as you can imagine, they'll have more of a risk for persistent symptoms. Okay, so I mean, although I'm not getting a lot into treating around the skull today, that's more in the advanced training. I will talk about some other approaches, but it's interesting just to talk a little bit about if light can actually get through the skull and have an effect. And there is research showing, this is the one paper, there's quite a few, that there is some depth, although penetration through the skull, and infrared can actually get through bone relatively easy, considering. And so roughly 5%, I think, was going through here. At 830 nanometers, that's the wavelength similar to what we use. Found that penetration depended on the anatomical region. So the thicker the skull, the less light that penetrated. So anywhere from 1 to 2% up to almost 12% might actually go through the skull. Red light doesn't really go through the skull very well. And you might say, well, why bother using red light? I'll explain that as we go along. So they concluded here that there are relatively low densities of light that can reach the brain. But interesting, there's so many photoacceptors, cytochrome C oxidase in neurons, that it doesn't take much light to stimulate them compared to other tissues in the body. So direct irradiation may be sufficient to change mitochondrial neuroactivity. In fact, that's what we're seeing with the research. The mechanisms, well, they're a little complicated. I'm not going to lie. You can look at the diagram here. The red lightning bolt is light going through the skull, can be absorbed directly by neurons. This will affect all sorts of different things, including increase in ATP, slight increase of extracellular nitric oxide, a small spike in reactive oxygen species. These are secondary messengers that will affect the cell, the neuron, to help protect itself and prevent it from dying or apoptosis. So it actually protects the brain from more damage or more cellular death. So it's actually really important to be treating these as soon as possible. And again, if you sort of look through the mechanisms here, there are some other wavelengths that are interesting. 980, 1064, these may have direct effects on ion channels. So we're starting to see the use of these wavelengths, and you can be rest assured that I think BioFlex will start to incorporate these wavelengths as well over the next few years, because the research is trending to show that this has a result, an effect on the cells, but different than on cytochrome C oxidase. So the big picture here is that photobiomodulation or photoneuromodulation, as I mentioned earlier, can have all sorts of positive effects, including increased blood flow. There's good studies on that, reducing edema secondary to trauma, improving lymphatic drainage, increasing neuron progenitor cells. These are like stem cells, increasing connections between neurons called synaptogenesis, anti-inflammatory effects. Oh, I don't know why there's a big white block there. Increasing anti-apoptosis, which means anti-cellular death. I guess that's what that means. So less likelihood the neurons will die, and reducing exocytotoxicity, which is a long word for toxins that can be negatively affect neurons. By the way, I'm not a neuroscientist, but we do have a neuroscientist in Vancouver, Dr. Jenna, who will be joining us, and she'll be joining us in future events as well. So if you get a chance to come out in Vancouver, join us. I think we're almost sold out. There may be a seat or two left, but I'll be doing it, I think, in a larger venue in the Greater Toronto area. By the way, let me know if you're interested in that as well too. Oh, there it goes. Neutrophins, neurotrophins, sorry, and anti-inflammatory mediators as well. So it's a fact that there's lots of different beneficial effects of photobiomodulation, but they can't all be explained by light going into the brain. And at BioFlex, 20, 30 years ago, we were treating patients after car accidents for whiplash and everything, and they had concussion. And so what we noticed was that there's symptoms of the concussion, like I'm not talking the neck-related symptoms. So we're treating the neck, right? For whiplash, right? And their brain fog, and they're sleeping, and their other cognitive issues were getting better, but we weren't touching the brain. Okay, so we believe that there's a very powerful systemic component to the effects, and I've talked about this in the past of these systemic effects and how they might. By the way, we're definitely going to go over time here, just so you know. These systemic effects are very interesting. So, you can have direct effects where you get light through the brain, through the skull into the brain. That will definitely be helpful. But indirectly, when you treat blood in and around the skull, including the neck, then this can affect immune cells and stem cells. And if you treat around bone marrow, like on the skull and deep to the skull is bone marrow, it can affect stem cells as well. So it will affect immuno cells, like white blood cells, immune cells, as well as stem cells potentially. And these will circulate and percolate, getting into the circulation of the brain to help heal. Interesting research. This is one publication A novel method of applying near-infrared light intracranially and its impact on dopaminergic cell survival. Now, this is Parkinson's, but it's interesting enough. What they did was they had a model, they have mouse models of Parkinson's, some of which they treated on the brain, and some of which they shielded the head and just treated the body, right? So, say cover the head, treat the body, or they treated the head. And what they found, remember, this is in a Parkinson's model. What they found was that there was an effect just treating the body on these mice models and also on the head. So clearly what they were showing was a benefit of systemic effects by treating the body as well. And that's kind of how, when you're working around the neck, in this case, you might have systemic effects, or even around the skull, you'll still get systemic effects as well. But using LED panels, like we started to market these as well, because we start to look into it and understand that it does create a very powerful systemic effect. Maybe not so much of a direct effect to deeper tissues, but certainly in the skin, you'll have a direct effect, but that light can be absorbed by the blood, which will have these positive systemic effects as well. Looking at the research, if I were to search for photobiomodulation or low-level laser therapy and traumatic brain injury, then we get about 45 results. And then specifically, if I look for clinical trials, we have about 5 published clinical trials to date on traumatic brain injuries. Not a lot to work with, but there's some. This one particular paper in 2014, they were treating LEDs over the frontal area. Sorry, I'm speeding this up a little bit. And what they found was that they showed significant improvements over time. They were treated with these devices, red and near infrared, similar wavelengths to what we use. And they found that there was improvement in executive functioning, verbal learning, memory, and long delay-free recall. But when they stopped treatment, they started to regress a little bit. And a follow-up to that was a little bit a bigger trial, again, where they're using, in this case, more near infrared. And these were LEDs, by the way. And they showed that application of near-infrared LEDs have been shown to have anti-inflammatory effect, inhibit microglial activation, and have strong antioxidant effects inside the cells, and can increase something called heat shock protein, which helps protect the cell. So this is just basically them talking a little bit about these studies that have been going on to show that transcranial LED therapy is effective, including improvement of sleep as well. Red light's also reported to have increased melatonin levels. So it's hypothesized that some near-infrared photons can reach the hippocampal, lateral, entorhinal cortex regions. And there's some interesting research showing that it may follow the sulci, which is, sulci are how the cortex is weaved in, and the light can kind of follow these cortices and go deeper into the brain. I'm going to present a little bit more on that in the advanced training. This was a narrative review on brain photobiomodulation, in part by Michael Hamlin, who, of course, is a well-known photobiomodulation researcher. And this is what they've come up with. So what the most important parameters are: wavelength, fluence, which is energy density, right? Operation mode, whether it's pulsing or continuous wave, whether it's lasers or LEDs, how long you treat, and how often you treat. Specifically, using red and near infrared, these are the most common wavelengths. And in part, this is because of their absorption pattern, as I've discussed. When you're looking at the sort of the fluence or the power density is watts per centimeter squared, and fluence is joules per centimeter squared. Whoops, back that up. Then they're starting to narrow down sort of the dosage range, 0.1 to 15 joules per centimeter squared. That's a little bit outdated now. I think they require a little bit more, 10 to 30, even up to 84 joules per centimeter squared. The issue here is that you want to go too high because then you'll cause heat. So They're still trying to figure that out. Hence, this is still very experimental. Not a lot of research to work with, but I think there's enough that we can lay the foundation that it can be very helpful with really no side effects. Successful outcomes largely depend on the delivered dosage, how often or how many sessions you treat, and sort of the guidelines. You don't want to overtreat, you don't want to undertreat. And again, this is still developing, so we're still trying to sort all of this out as well too on a clinical level. Pulse rate, it seems that the most effective pulse rates are 10 hertz, 40 hertz, and 100 hertz. These seem to follow the different wave forms for nerve activity and nerve transmission. Dr. Jenna will talk a little bit more about that in the advanced training course. So really, it's still considered experimental. And really, we're still working around with these dosaging and parameters as well. However, we do know that near infrared, well, that's going to penetrate by far the deepest. So that makes sense to use. The fluence, roughly 10 joules to as high as 140, starting off pretty low. We actually start pretty low, like 10 or so, maybe even a little bit lower. And the treatment locations, well, I mean, they can vary. And again, I don't have the time to go into all that transcranially. We'll be doing that in advanced training. I'm going to talk more about the neck today. Other devices have treated intranasally as well, too. As I mentioned, these are the pulse rates that we tend to use. And it seems that these pulse rates may improve depth of penetration, but probably have a better effect with respect to nerve conductivity and how it affects the inside functioning of the nerves as well. Both lasers and LEDs have been used, and they have different advantages, but lasers are good, but they you can only have so much power because then it creates heating, right? LEDs can treat a larger surface area, so there's advantages with that. They're very safe as well. So, advantages to both. We use a combination of lasers and LEDs for professionals. At home, it's just LEDs. All right, so how to use our equipment for healthcare professionals that use our devices? We have two types of large surface arrays, a dual 240. You're familiar with these placements on the cervical spine, but you're going to shift it up higher over the suboccipital region. Okay, so you're focusing more higher up, and you can adjust the lateral placements as well. So the kind of like 3 placements as you would typically treat a neck, but you're going to adjust them a little bit higher up. If you have the 180, the slightly smaller array, then you'll do 4 placements. You can see the one that's more superior on the suboccipital region, and also one to the mid to lower C-spine to cover that area as well. More important for whiplash-associated issues in the spine itself, and then the lateral placements as well. And these protocols I'm going to mention now, well, of course, these are off-label. They're considered experimental, and this has to do with regulatory oversight. We do not have approval, nor does any manufacturer have approval specifically to treat post-concussion syndrome, but you can imagine you can use it to treat off-label, but also to treat pain and headaches and other things that you would normally be treating anyhow with a concussion. So there are some indications for sure, but we can't say specifically for post-concussion. So typically, the first stage and the lowest sort of parameters here is treating the neck. Now, notice I have 4 placements. That's for the dual 180. It's only 3 placements if you have the dual 240. And the red is continuous wave. The infrared is pulsed at 10 hertz with a duty cycle of 60, although you can even lower that. If the patient's sensitive, you can lower that to 10, 20, 30% duty cycle. When you get up to stage 2, well, you can start to increase a little bit more. You can try the 40 pulse rate, increase the duty cycle. I'm sorry, this 50 should be 60 plus, so 60 upwards as well. And then when you get into the final stages, You can start pulsing at 100, again, the infrared and the red, and maximize that duty cycle. I'm going to back up a little bit and just kind of talk a little bit about this. Even though it says 60 here, I'm going to say that you maybe try a little bit lower. Again, if they're sensitive. The stage 2, you can start to creep up towards 50, 60. In that first stage, 20, 30. I meant to edit that, and that was my mistake there. Okay, now again, this was meant as a very cursory level introduction to treating post-concussion syndrome. Should you want a lot more information, especially as a clinician, you can join us in Vancouver or in Toronto for advanced certification training course on this, with obviously a lot more information and also ways of treating transcranially, a little bit more involvement about treating auditory issues as well. And also some other different types of applications for post-concussion syndrome. If you're not familiar with our Wave line of products, these are for consumers. We've released a very interesting device, a therapeutic cupping device. This does combine 3 levels of red and near infrared light that is based on our BioFlex protocols, 3 different stages or levels that stimulates the skin and the tissue to combine photobiomodulation with therapeutic cupping called the Surge. And we also have wearable technology as well called the Nano. I think they have a sale on right now. You can get one 50% off or buy 2 and get 1 free. Again, we're in Vancouver this weekend, heading out tomorrow morning for both a Light Up Your Practice, which is a fundamentals of photobiomodulation on the Saturday, and on the Sunday, an advanced course on treating post-concussion syndrome. And as I mentioned, I'll be doing this in Toronto, so stay posted for that as well. Now, I'm not sure if anyone has any questions here. I shall see. I'm going to ask you to type in the questions into the chat box because I don't see the question box. Okay, just waiting for some questions in here. Can we review the parameters, or will we be getting these handouts? So for the advanced training course, you'll be getting a manual with all the protocols, both transcranially and for the neck, and also for auditory issues as well. And we'll delve a lot more into the protocols in the advanced training. Does hair decrease the absorption? It does. Unfortunately, it does decrease the absorption. With our arrays, you can, when you put it into the scalp, like the forehead's easy. Around the scalp for transcranial, when you place it, you'll want to kind of gently move it back and forth to displace as much hair as possible so the diodes that are protruding out can touch the scalp. And that's a big advantage of our equipment, is the diodes protrude out. So yeah, the hair does reflect a fair amount of energy, and that's why you have to play around with the duty cycle and the dosaging, depending on the thickness and the color of the hair. A question about treating someone with stroke. I can't make a generalization. We do treat stroke, but as a healthcare professional, yes, you can do that off-label, but I'm not about to talk about that right now for the sake of clarity. The advanced training, I'm hoping to do live online as well in Toronto. I can't do it in Vancouver, but in Toronto, I think we're going to set up to stream it live. So if you're not in the GTA, you can watch it live as well. So not this weekend's one, but the next one, I will do in-person live and stream it live. I can't do it in Vancouver because we have limited capability. Probably because I'm not tech savvy or something, I don't know. If you do 10 sessions of post-concussion syndrome, then stop. Will the symptoms come back? I mean, in general, what you're trying to do with this therapy is help the healing. So really, you keep going until the person's symptoms are resolved and they should be okay. There can be regression of symptoms depending on circumstances, like they go back to activities too soon or whatever. But the idea here is to actually help it heal faster. I'm not really getting into the personal assistance for treating post-concussion syndrome here. Again, this is more towards healthcare professionals and using our professional equipment. I don't have a date yet for the advanced class, but I'm thinking late September, early October. So late September, early October. I'll put out a date in the next month or so. So you guys should check our website for that as well too. With moderate to severe brain injury, could treatment go on indefinitely? Well, here's the thing, right? So when you're dealing with a moderate to severe brain injury that is almost sometimes considered permanent, you can still make good improvement on the symptoms and help patients. So they might need ongoing treatment. It's almost like it's a progressive issue. So the prognosis may not be 100% recovery, but you can help them improve their symptoms. Whether or not you need to continue to treat on an ongoing basis, probably. I don't think there's enough research or understanding on that, but I would say yes. That's where having a system at home would be helpful. And we're, how should I say this? We're teaming up with another manufacturer called V-Light. They'll be at the Vancouver event, and they have some nice devices for treatment specifically at home. Okay, that's it. Thanks everyone for watching, and I'll see you next time. Bye now.